Put us all on mute and let our participants in. You all have a fantastic session. Hello, everyone, and welcome to today's virtual interactive panel discussion brought to you by the ACHE of Northern New England. My name is Tia, and I will be serving as your ACHE technical host for today. Before we get started, I would like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session. The chat function will be available to you throughout the entire event, and we absolutely encourage you to use it to help keep the session as interactive as possible. We encourage you to go in that chat box, say hello, introduce yourselves, ask questions. We welcome hearing from you. This event is being recorded and will be available for viewing in ACHE's Learning Management System in approximately 2 business days. Today's session is worth 1.5 hours of ACHE Virtual Interactive Education credit. To earn this credit, you must be logged in for the entire 90 minutes of this event. All attendees who meet this requirement will have their 1.5 Virtual Interactive Education credit applied within 2 weeks from today's event. We do encourage you to complete the evaluation for this event. I'm going to be dropping the link in the chat box shortly, and then I will reshare it before we close out. Now, to begin, let me turn it over to Karen.
Good afternoon, everyone. Thank you for joining us this afternoon. And our topic for today is fostering inclusion of LGBTQ patients and employees. This event is being sponsored by ACHE of Northern New England. And our faculty joining us this afternoon is Bentley Gallo, who's the Manager of Patient Experience and DEIB at New London Hospital, Dartmouth Health. Bobby Kelly, a family medicine physician, who's also the Medical Director of Addictions Treatment at Beth Israel Lahey Health and the founder of Empower Medical. And lastly, Terry Malcolm, who's our Vice President of Diversity, Equity, Inclusion, and Belonging at Dartmouth Health. Our agenda this afternoon will be to cover the topics of common obstacles LGBTQ patients face in our communities and hospitals, addressing the fears and anxieties the LGBTQ population may have when seeking care, establishing LGBTQ employee groups, incorporating the concepts of caring for LGBTQ patients in continuing education and training for staff, and lastly, best practices for recruiting, retaining, and developing LGBTQ clinicians, caregivers, and healthcare leaders. I'm going to turn this over to Bentley Gallo, who will begin our discussion this afternoon, and he will provide an introduction and also some foundational information and slides on this information. Thank you. Bentley?
Thanks, Karen. Hi, everybody. My name's Bentley. I am the Manager of Patient Experience and Diversity, Equity, Inclusion, and Belonging for New London Hospital, which is located in New London, New Hampshire. We're part of the Dartmouth Health medical system. We serve a predominantly rural community here in New Hampshire, but a little bit about me, I guess I'll share. My background is in patient advocacy. I started as a secretary actually at Dartmouth Hitchcock in Lebanon, answering calls for the patient relations department. And it's where I really discovered that I had a real interest in hearing about patients' experiences and utilizing that information in productive ways for things like process improvements and that sort of thing with the work that we do in healthcare. And it led me to my current role here at New London Hospital. My role here at New London is the Manager of Patient Experience and Diversity, Equity, Inclusion, and Belonging. So I'm very glad to be able to be here and share a little bit of the information that I've learned over my time in this role. And one thing I say about myself is I consider myself a continuous learner, and I'm very interested in not only learning all that I can, but finding avenues to share that information with people in productive ways. So I hope that some of you get some information out of this that is valuable for you. When I came into the DEIB responsibilities in my role, I had a number of staff reach out to me to really ask for my input in terms of how to be respectful when speaking with LGBTQIA plus patients, which it's really important to me personally as a gay man living in New Hampshire, born and raised in New England, actually. So I've lived within this patient population my whole life, and I have very firsthand personal experiences of trying to navigate healthcare. I've been working within healthcare for over a decade now, so I'm old hat at it now. But when I was young and unsure of my sexuality and trying to navigate healthcare, it can be a very scary place for members of the LGBTQIA plus community. So I find any opportunity that I have to do this topic due diligence and share information with people is personally gratifying to me. So when I had the staff reach out to me with these questions of how can we best be respectful, I did some more learning on my own. I didn't want to just speak on lived experience, and I found a resource that I thought was really important to just let you all know about, which is the National LGBTQIA Health Education Center. They have a number of certifications and that sort of thing that staff can take and utilize that information. So I actually completed a number of those trainings, and some of the content that we see in here is based on information from that organization. So let's just jump right into the content here. And if people have questions, please feel free to throw them into the chat, and I'll do my best to monitor as we're going through. So the first thing I want to do is I want to give credit where credit's due to one excellent resource that I'd recommend anyone looking to brush up on the field of care experience would be the Barrel Institute. I joined the Barrel Institute several years ago now when I was doing that work as a patient relations specialist. But they're a leading resource and think tank really for care experience leaders and people who want to learn more about this topic and really do their due diligence. I've had the opportunity to meet with their CEO, Jason Wolf, a number of times and hear him speak. And one of the things that he's always said, which this is a quote from him on this screen here, is that healthcare at its heart is about human beings taking care of other human beings. And I think of this as a foundation setting statement for me personally. And I start my presentations for staff here at New London Hospital with this quote because I feel like it really encapsulates the reason why each of us got into healthcare. Whether we're providing the clinical care to the patients directly or even administrative staff who are helping to support the daily operations of a healthcare organization, we all are here to really advance that mission of delivering excellence to our patients, our families, and our communities. And I think that this hits at that. It also hits at the really unique piece about healthcare is that while we work in healthcare, we all also have personal experiences, either of the ways in which we received care or helping support a loved one and a family member as they navigate their own health issues. And we can sort of do that mental work if we try of putting ourselves in each other's shoes. So I ask people to do this a lot, especially when I'm doing advocacy work for patients, sharing experiences in productive ways in order to improve experiences and how we deliver our care. So I wanted to ask everybody on this call to take a moment and humor me with a little thought exercise and just think of a loved one, a close family member, a best friend, a son, a daughter, sister, or a brother. Think of them traveling somewhere or moving to a new city or a new environment or across the country when they suddenly find themselves needing care in an unfamiliar environment. And what kind of care do you hope that they receive from that unknown healthcare organization? And I wanted to see if people would put in the chat their thoughts on that question. Thank you, Bobby. I see compassionate and competent healthcare is one. Any other thoughts? Reduce confusion, have a resource available to help. Culturally responsive care and compassionate care, supportive and compassionate care, understanding, educated professionals, equitable healthcare, compassionate person-centered care. A couple people say person-centeredness, equitable, compassionate care, individualized care, equitable and compassionate. These are really timely, compassionate, and confident. So really, this is hitting at the spirit of what I was hopeful we would get out of this exercise, is that we all want the best for our loved ones. And I want to just start this conversation off around how we care for the LGBTQ community by reminding everybody on this call that this community that we're speaking about is somebody's son, daughter, sister, brother, best friend. And I hope that we consider that as we provide care to them, and make sure that we're remembering that empathy and compassion and kindness should really top the list of how we deliver that person and patient-centered care. We can use this to connect with all of our patients and reduce fear and that sort of fear of judgment or stigma that can come from healthcare encounters, especially within this patient population. So on this next slide, I wanted to just share some data with you and remind everybody that this community are people of all ages, races, ethnicities, and they live in all parts of the world and country. However, like human beings tend to be, this community is, everybody in it is unique. What they have in common is the experience of being a sexual or gender minority within a larger straight society. And I wanted to share some data from a Gallup poll that came out in 2022. And according to this Gallup poll, 7.2% of adults in the US identify as LGB or T. The more recent update that I had to this number was actually 7.6%, but I didn't get a chance to include it on this graph. The particular poll that I'm referring to didn't ask respondents to identify as any other sexes, sexual identities, or sexual orientations, which are included in the larger acronym of the Q, I, A, and plus, which we'll review in a moment. But I like this graph on the left because it really breaks down from this question being asked over time from 2014 to 2022. And we can see that over time, Gen Z and millennials have increased their likelihood of answering positively that they identify as a member of this community. Perhaps because society is moving to be more understanding and inclusive over time, people feel more comfortable. But it also highlights that we have patients in every single one of these generation groups that identify as a member of this community. So really just remembering, and I highlight with staff, that we can't judge a book by its cover and think that we know things about our patients. We've got to think instead about how we foster psychological safety and connection with our patients to share information openly with us, like information about their sexual orientation and gender identity, or SOGI data, with us. And we can do that by creating inclusive cultures in our workplaces. It does take a bit of learning to understand all the terms and definitions as they currently exist, and learning how to respectfully ask questions of patients, as well as to earnestly and openly apologize if we cause any offense along the way. But if we put in the work, this can create environments where our patients in this population feel safe to trust us with what they need. So when we talk about learning and putting the work in, I thought it was really pertinent to start with sharing some defining terms, knowing that some of us on this call may be more familiar versus some of us on the call might be less familiar with this acronym. So the LGBTQIA+ acronym stands for lesbian, gay, bisexual, transgender, and the Q can either stand for questioning or queer. I stands for intersex, A is asexual, and the plus is really everything else. So we won't get too granular and go over each of these here, and you can read the ones that are particularly new to you and familiarize yourself with them. The real caveat here would be the Q1 of questioning, really is somebody who isn't sure about their sexuality. And then queer is the idea of an umbrella term that describes people who think of their sexual orientation or gender identity as beyond societal norms. And the queer terminology is actually something that the LGBTQIA+ community has reclaimed in recent decades to take away the stigma and bias that was once associated with that term. And then the plus really indicates that this community also encompasses all other sexual and gender minorities, people who are pansexual, agender, same-sex attracted. There's room for you too in this community, and you can find friends and allies here. I will say that another caveat with these terminologies is that this is really culturally specific to the United States material here, and that sexual and gender minorities may use other terms and concepts in other cultures and countries. So just be mindful about that. And on this slide, I wanted to talk a little bit about the impact of bias and discrimination on this patient population. So the LGBTQIA+ community are a minority within a primarily straight or cisgender society. Cisgender meaning you identify as the sex that you were assigned at birth. Being in this position can result in higher levels of daily stress for members of the LGBTQIA+ community. This increased stress is sometimes known as minority stress, where it can really result in a lasting fear of discrimination in the future. So being a member of a group that experiences discrimination can also lead to unhealthy coping behaviors like drinking or substance abuses and broad health problems like increased anxiety, depression, social isolation, to name a couple, as well as a general fear of healthcare. I know that in my early years of trying to navigate my sexuality while navigating healthcare, it was a very scary time for me personally, being unsure about who you can speak to without judgment, and being unsure if that information is necessarily safe with that individual. So I think a lot of, again, about how we reduce the idea of stress that our patients experience when they're navigating healthcare and reduce fear. When I talk about fear a lot in my work as a patient experience leader as well, thinking of the effects that fear has on our body and our ability to really perceive what's going on around us. When we think about fear and the effect on our body, our blood pressure is rising, our adrenaline starts pumping, and our brain starts ticking and circling around, how do I get myself out of this scary situation? When a patient is in that sort of situation where they're stressed or anxious or nervous and scared, it can actually start to reduce their ability to understand the information that's being provided to them. Can relate this back also to Maslow's hierarchy of needs. For those of you who aren't familiar, it's a psychological framework that really specifies what human beings need in order to self-actualize or meet their full potential. And you work your way up this pyramid, and at the bottom of it are things like our food, water, and warmth and rest, but it's also our feelings of safety. And I think that that safety starts to extend into the idea of psychological safety, where if you don't feel psychologically safe in a location, it becomes a deterrent to understanding and fostering connection with the people who are trying to provide care to you. So really just being mindful about that. And then also understanding that negative experiences become a lasting story for our patients, and they have a real impact on them. And what I mean by that is that when we have a bad experience in a situation, our brain starts to wonder if it's going to happen again. And we start to almost expect it, and it can become a self-fulfilling prophecy in a way. So instead, I think about how we can make healthcare a less scary and stressful environment for patients in this population so that they don't have to worry and they don't have to feel fear when they come in through our doors. And I have on the next slide here just some strategies that I think are pertinent for any healthcare organization, and the staff particularly working within it. So some of my things not to do would be do not stare or gossip about a patient. And I think that that would apply for any of our patients. A really pertinent instruction here, though, would be don't ask questions that are meant to satisfy your curiosity unless they're medically appropriate to the care that the patient is receiving. I think that that's really important for honoring our patients' privacy in situations and making sure that they feel comfortable. And then some of the things that we can do would also be to speak with members of this patient population with the same welcoming tone that you use with all of your patients. I'm sure that your staff are very, very skilled at this. Patients within this population, they might go by a name that is not the same name on their medical record, or they might ask you to call them a gender that isn't reflected in their medical record. And those are, we call those affirmed names or pronouns. And what I would be mindful of is that when you're speaking to patients, honor those affirmed names and pronouns when you're speaking either to them or about them. I think that this is especially pertinent if we're providing care to a patient in a clinical environment and they ask us to call them by a certain name or a certain gender, and then we turn around and walk out the room and we're standing outside the door and we say to our colleague, and we refer to that patient by a different name or a different gender, and they could potentially overhear that, that becomes a real dissatisfying and negative experience for those patients. So be mindful about that and make sure that we're honoring those requests along the way. And then Knowing that we're all human beings taking care of other human beings in healthcare, we know that we're not always going to get it right 100% of the time. And the really important piece here is about making sure that you have a plan in place for service recovery or apologizing when we get it wrong. That's just as simple as offering an honest apology to somebody. I am so sorry, I didn't mean to offend you. What term do you prefer I use going forward? I want to be respectful. Being able to say that to a patient admits that we are also trying to improve along the way, and can help restore that trust that a patient has in us. And then just some things to keep in mind is that the terms that we reviewed on that previous slide, again, it pertains to American culture particularly, and they might be different if you're traveling and that sort of thing. Those terms and definitions can also change frequently. So you might encounter a patient, say a year down the line, who uses a term that you're not familiar with. Ask them what that means to them if it's something that you're not familiar with, and then use that term that the patient is using to describe them, just like we would with any of these other terms, to honor that request. And then some strategies that I have for healthcare organizations in general would be to, number one, foster a welcoming and affirming atmosphere. And I think of that about the values that our organizations set to make sure that we are aiming for a specific type of atmosphere here and going to reach our mission and our vision. Also, sort of thinking about how we're hiring, and hiring with behavioral-based interview questions is a way that we can ensure that we are hiring people into the organization that really match those values. And then review forms that you may have that are presented to patients that we ask patients to fill out, just to make sure that those forms have inclusive language in them. That's a really important piece. Try and make the terms as gender neutral as possible. And then when we're speaking of gender neutral things, you could also think about gender neutral, like bathroom accommodations. That is an easy movement that we've started to make here in the Dartmouth Health System for single occupancy bathrooms, changing the signage to sort of an all gender signage. And then also think about what is the language that we're using, and what is the what are the visuals in our signage that we're presenting to our patients or in our advertising campaigns? And is there a way to sort of improve that diversity as well? The second step would be to just make sure that you have data gathering tools in place to gather sexual orientation and gender identity data, and make sure too, along with that, that staff understand why we collect that data, and then help your patients to understand as well why we collect that data. And that data should be used to support data analysis through patient segmentation. You can segment patient populations on patient experience scores, for example, to see what patients within this patient population are experiencing in your healthcare organization. And then provide up-to-date clinical care best practices for patients. And part of that too is developing strong referral networks to LGBT plus positive organizations and other providers. I think the worst thing that we could do is refer a patient for necessary specialist follow-up care to somebody who isn't as inclusive and supportive as we are trying to be within our organizations. And support community collaboration as well. There are plenty of LGBTQIA plus organizations out in all of our communities, and sometimes they can become a really great voice for patients who might be scared to access our organizations or might have had a bad experience in the past, so that we can identify things that we might not see working in these environments every day and utilize that information in productive ways. Lastly, I would say work on developing trainings for staff. One of the things that I did with the material from the LGBTQIA plus Health Education Center material was I developed a training on caring for LGBTQIA plus patients. And a lot of this material is in that training. And I actually will go around to departments and present this in person when requested. And we added it here at New London Hospital to our e-learning system so that people can actually opt in and take this at their leisure. I also was able to get time in our general orientation session to talk about patient experience and DEIB and the importance of creating these psychologically safe environments for our patients and our staff. So I recommend you all look for similar ways. Other ways that you can help support this community would be employee resource groups. They're a great way to really foster allyship and connection, and for people to really break out of their silos that sometimes exist in healthcare and find new friends in other areas. I would also say make sure sure that your board knows that you're taking these steps and that they're supportive of these steps. They need to know the why that we're working on this to create these more inclusive environments. And yeah, that's really all of my slides that I had for you. But I hope that some of you have gotten some positive information out of this. We're at the end of this session, we're going to send out some of this slide deck, which includes just some session materials and links at the end of it that might be helpful for all of you. And I am going to hand it now over to Bobby.
Awesome. Thank you so much, Bentley. Can you guys hear me? Thumbs up. Perfect. I don't have any slides. As Karen mentioned earlier, I'm a family physician, and I'm actually going to give a little bit of a narrative example of some of the things that Bentley was describing as sort of best practices and awesome ways to create and foster environments in your. Sorry, my spotlight. I'm gonna get my spotlight off of my face. Unless somebody did that on purpose. Can you still see me? It was a little too much for me to see my face so big. As far as how to implement some of those best practices, right? So not every organization has a Bentley. Bentley is amazing and has a lot of resources and knowledge and intel, and many organizations might feel potentially intimidated as to where to start, right? And so, like I said, I'm going to give a little bit of a story as to how I was a part of some of that work at Exeter Hospital. Some of you may have heard me speak. Previously, I have been on a few New Hampshire Hospital Association calls and meetings about my role at Exeter Hospital in leading health equity work and establishing what we wound up calling the LGBTQ Health Advisory Committee. Um, that committee itself wound up actually dovetailing into and becoming the foundation for a larger diversity, equity, inclusion, and belonging leadership council that I found myself at the helm of. Again, Terry, I talked about not knowing what I was doing. I was, one of the leaders of the, like I said, the LGBTQ Health Advisory Committee, and that spawned a lot more passion about trying to build a DEI organization, a council in our small community hospital. And it was pretty early on. So I'll just start from the beginning. Back in 2018, based on patient feedback, we had a patient feedback card, right? So all those requests for feedback from patients from a survey. I actually have the quote. I bring it with me when I do these talks because I think it's pretty powerful. And the patient feedback was as follows, quote, "Your clinical staff need a transgender cultural competency. I would like a firm commitment that your hospital will try harder in the future to ensure your transgender patients have a positive experience," unquote. So this feedback made its way through the formal, patient feedback chain, and actually our director of risk management and patient rights called together a group, a number of people from across the organization to talk about this and to develop some sort of um, committee conversation, starting point to address these pieces of feedback. At the time, I had some personal experience with working with centers of excellence in LGBTQ health, both in medical school in Philadelphia, and then here when I moved up to New England at Fenway Health and the LGBTQIA plus health education center that Bentley mentioned. They have some really fantastic resources, but that was not necessarily part of my um, uh, work and focus when I was at Exeter. That being said, I found myself called to the table, and we were having a really robust conversation about ways that we can address this. We actually decided as a group that we would not just restrict our focus to the transgender population, and we decided to actually expand it to the LGBTQ population writ large. That led to the development of a really awesome multidisciplinary team and group that I miss because I'm not actively at that organization anymore. Oh my goodness, Eileen, hello. I see somebody from not to call you out, but you popped up on my screen. Um, but it was a really wonderful, and is a wonderful group of people that included folks from the inpatient world, the outpatient world, from patient registration, from clinical entities, nursing, HR, um, leadership. It was really important for me to, as I led from participant to co-leader, to make sure that there was representation from all of these different facets of the organization, so we could not only understand the different implications of what we were being asked to do and how it could be done, but also how to get stuff done, right? So it was really helpful to have somebody on each of the areas. And so I'm also proud to say we were one of the first groups, we were the first group at the Exeter Hospital System that had representation from patient and family advisor. I know that many hospitals, this is like old hat, it was like cutting edge for us. And so it was one of those things where we made it happen, and it was really impactful, and I think it made our work that much more effective. So some of the things that we did basically are very, um, the last slide that we just had up there, Bentley, that he had up, was it would have been nice if we had that roadmap. I didn't, but now you all do. So basically looking at things that we can address, including education of staff and providers, using some free resources, to the point where we also put together a virtual symposium that was able to offer continuing medical education and continuing education units. We did that through COVID, which was quite an ordeal, but it happened. It also led to some operational and organizational improvements. We included information, like Bentley was saying, at orientation. And again, it can be done pretty robustly the way that Bentley was describing, with LMS modules and things like that. Or, we created a one-pager that was included in a folder, right? So it sometimes can be very lo-fi and still have some high impact. We updated some forms that we identified as being relatively outdated. I myself filled out a couple of forms, as a gay dad in my community here. Many times I had to fill out my information on the mother line, and I then promptly provided feedback. I have a lot of respect for mothers, but I am not a mother, so please update your form, right? So there were opportunities for improvement, and folks listened, especially when it's done, I think, in a supportive way. The other thing I would say that I'm really proud of is that we started off in the beginning to, if you haven't heard of this, there's something called the Human Rights Campaign Health Equality Index. And there was something in 2018 that we were interested in pursuing. If you haven't heard, you can just Google it. But the first couple of times we did it and submitted things, and I think the first time we did it, we got like what I called bronze level. It wasn't called that, but it was like, preliminary. Yes, you did a good job, but keep working. And as of 2024, just before I actually left to Exeter, we were given, and currently we're the only organization in New Hampshire who has the LGBTQ plus healthcare equality leader in New Hampshire with a score of 100. So that shouldn't imply that we don't have any more work to do, because we definitely do. But as far as the criteria that are set up, that was work that we did, and I'm really proud that the group fostered. Some other things that I would sort of throw out there as sort of useful to consider is, yes, we put together, and many places can put together different modules for learning environments right out there to people. But sometimes the people who actually would benefit most from the education are not the ones who are signing up. And so I was able to work with HR and many department heads to try to really encourage their team to come. One of the sessions I was really excited about, and actually want to bring to my current organization, is something that we called conversations. And basically it was a virtual webinar like this, but we set the stage for a safe space where we were going to have conversations, and we were going to tackle different topics, general topics each time. And we were going to use real stories of real challenging, true challenging stories and circumstances that popped up in our organization, de-identified, of course, but just creating a space to be able to say, okay, so let's talk about this, right? What are some of the if anybody was involved in this, feel free to talk. If you don't want to specifically talk, let's just talk about things that might have been done better, et cetera. Our first session, because a lot of the work that we did as far as the LGBTQ Health Advisory Committee, our group was primed, we were able to have some really good open and honest conversations about some of the struggles, for example, that in our day surgery department, they were having some challenges and troubles understanding how to best serve some of our trans patients. But I think just as importantly, that framework we were able to apply sort of the next time, a couple months later, where we had what turned out to be a more challenging conversation for us as an organization that was focused on race and ethnicity, which, especially in New Hampshire, I think that conversation, I'm curious to hear what Terry has to say, can sometimes be um, challenging in a different way because we are a very homogenous state, at least as far as race and ethnicity, although getting wonderfully more diverse, which is very exciting. So I don't want to take up too much time. I think the other thing I would just say is, as Bentley mentioned, as far as the SOGI data, there are, and some of the questions that we have that we're going to tackle in our breakout group, there are some requirements and CMS and Joint Commission are at the point now where you sort of have to meet certain things in order to be able to take insurance or to get paid. And so, I mean, I'm glad that it's becoming sort of the standard, but a lot of that has to do with collecting SOGI data, or the sexual orientation, gender identity data. That being said, I remember when we first had our EMR allow SOGI data to be collected, it is our system, the way that our IT and our operational people had set it up. We had the ability in our EMR to collect the data, but that option was only given to providers, and providers were not folks who uniformly went into that section. So it was one of these things where we had all the tools, but we did not create a system where we can actually successfully collect that data, but we were checking the box, right? So it's important to, I think, to not only check the box and meet compliance, all of our legal folks will appreciate that, but it'll be important to make sure that we actually collect valuable and useful data for so that we can actually figure out a way to help better take care of our population. I'll leave with the little story of I moved, like we had mentioned in my intro, from Exeter. I'm now working at Beth Israel Lahey Health down in Mass, where I'm medical director of addiction treatment, and I certainly take care of LGBTQ patients from in my setting, but that is not a focus of my setting. I definitely miss that personally because it's something that I was pretty passionate about, and so there is and continues to be opportunities for medical providers to learn more about best practice as far as LGBTQ health. But until we get to the point where it's sort of standard practice, I actually started my own little micro practice where I'm continuing to see folks for LGBTQ health sort of expertise or consultation. So I missed it. My husband was really supportive of me in doing that, and so I'm really jazzed to be able to do that, as well as continue to be in a workplace that does foster just diversity in general. And so with that, I'm going to pass it off to Terry, because I know that that is Terry's jam, and she has some excellent expertise and I'm sure some great stories.
Thanks, Bobby. And can everybody hear me okay? Okay, good. Thanks for the verbal nod. So it's always hard to be the last and especially to follow Bentley and Bobby, who are just so full of knowledge and information. So I hope you will bear with me and just be patient, as I try to contribute a little bit more to the conversation and maybe stitch together some of the things that both of them shared. My name again is Terry Malcolm. I'm the System Vice President for Diversity, Equity, Inclusion, and Belonging at Dartmouth Health. I've been in this role just a little over 2 years now, and was extremely attracted to the possibility and now becoming the reality of creating an infrastructure for the ability to foster a culture that is supportive, diverse, and inclusive. And so that's really my task at Dartmouth Health, and it's really exciting to see the progress that we've made in the couple of years, knowing we still have a very, very long way to go, but the key is really to continue to make progress. We're not here to be perfect. We're here to continue to evolve and to grow and meet the needs of our patients. Um, in a prior life, I was a practicing obstetrician and gynecologist, and what was always really a cornerstone to me in my clinical practice was for my patients to always feel heard and for them to be supported and for them to be empowered. And so I wanted them to be empowered through education. And in this role now, I've really come to realize how very little I received in terms of training and education when it comes to treating the LGBTQ plus population. So it's been over 20 years now since I finished medical school. And if you are finding yourself in a place where trying to reach your providers, trying to reach your medical healthcare professionals is at times a challenge because there's a disconnect in the education and the level of awareness and knowledge. No, it's because we didn't receive that training. We didn't receive that education. It has not been fully integrated into the medical school curriculum. We're seeing more of it now, but it wasn't there over 20 years ago. It was something you really had to go out and actively seek. And I'm so glad that we have more of our providers today who recognize that in order for their patients to feel empowered, for them to feel heard, and for them to really be supported and know that they have a trusting provider in order to deliver their care, it requires more education and more training and real intention beyond what you may have received in your initial training or your initial residency. So to share some of the things that we've done to really help meet our providers where they are is that we've provided them with education and not making any assumptions about how much they may know or how much they may be complete experts, but actually really just providing a safe environment for them to be able to learn and ask questions and lean on one another. And so we made safe spaces conversation, safe spaces training available to all of our providers. And we made it open initially to all of our employees, over 13,000 employees within Dartmouth Health, and then really targeted our healthcare professionals and our physicians for the step 2 certification. So we made it as easy and as simple as possible for people to just register online and then participate in 2-hour sessions online, sign on from wherever you are, made sure that those sessions were also available after hours so it would not interfere with any clinic time, or if you have kind of a standard 8 a.m. to 5 p.m., 9 to 5 job, we wanted to make it available. Well, it maybe was a little more difficult for those that work 12-hour shifts or those that work an evening shift. We also tried to have at least one session available in the early mornings or during the lunchtime hour to try to really and truly meet individuals where they are. Let's remove as many as we possibly can. And so we had really tremendous participation in that session and hearing a lot from our employees that said this was very helpful. I learned things I never knew before, had an opportunity to ask questions from experts and our experts made it very clear that you could ask any question there. It was very, very open, and very, very safe, where our trainers, our facilitators were also willing to share their own personal experiences and their own personal stories. So there was a lot of learning through storytelling. There was also a lot of learning, through didactic. So we really tried to meet the very different learning modalities of our employees. So I think that was one thing that we thought was that was really very beneficial. And to that point, what I would also share is bringing in experts, depending upon where you may be in this journey to improve the care delivery model to the LGBTQ plus population. It can be very helpful to reach out to consultants. It can be very helpful to reach out to individuals who really are knowledgeable, certified, come with a great deal of experience and know how to teach it, and really know how to deliver it to your particular institution or your particular department, depending on where you are. And that has been extremely beneficial to us, is being able to tap into the resources of others. And this has also been a great community where we have felt like we could knock on the doors of hospital neighbors and say, hey, what are you doing over there? Like, it seems to be working very well for you in your institution. Can we learn from you? Fenway Health is one of those organizations that we've reached out to. The University of California at San Francisco, real leaders, real trailblazers that are, where we aspire to be. We have connected with them to establish those relationships, to ask, what resources do you have? What webinars or what modalities do you have? Like, what more can we learn and incorporate based on where we are and what our goals are? That I think, has really been wonderful in terms of developing those partnerships at other institutions. So don't be afraid to ask for help, right? If I think in any other situation, if you were sinking, if you were struggling, the first thing you would do is, raise your hand, and you would send out an SOS signal and say, I need help, please help. I think what we have definitely learned in our journey is the more that we speak up and we ask for that help and we ask for that assistance, we just get inundated with assistance and with resources, and really have not had anybody turn us down or tell us no. Another piece that we've really focused on, and Bentley mentioned this in his presentation, are our employee resource groups. And while the employee resource groups is not specific to the care delivery model, what we realize is that our employees are our patients. And so many of our employees utilize and see Dartmouth Health as their primary institution of care. It is where they are going to go to receive their care, to receive their test. It is their healthcare provider of choice. That is something that we do not want to take for granted. And so we need to listen to our employees, who are also our patients, who are telling us what is working for them and what is not working for them, as it relates to delivering that high quality, compassionate, patient-centered, culturally responsive care that we all said that we would want to receive for our loved ones. And so the employee resource groups have been very instrumental in helping us to reshape how we deliver care. And so we have 9 employee resource groups to date, and one of those 9 is the Gender and Sexuality Alliance Employee Resource Group. That is actually our largest group with the most members. All are welcome, and what we have found is that within our employee resource groups, it's individuals who may align with the identity, but it's also those who want to be allies. So no one is turned away. And our employee resource group also really plays an important role in the retention and the overall, joy and well-being of our employees. And so we look to those groups to help us with our business model. If we don't have employees that feel heard and feel valued and supported, they will not be able to deliver the best possible care. So a big part of my role is really in supporting those employee resource groups, because the individuals are giving of their time. We want them to be recognized for the time that they're giving, but we don't expect them to also give financially. So they need support. They need financial support in order to be able to hold any of the activities, the learning sessions, the education training, opening the booths. They need financial support in order to do that. And so I really take it very seriously within our Office of Diversity, Equity, Inclusion, and Belonging that all of our employee resource groups will be well funded. We ensure that every year there is budget allocation set aside for our employee resource groups um, to deliver on all of the activities that they have planned for the year. And those activities, those programs, we ask them to create a budget. We ask them, really to create a calendar for the year, how all of this is, how everything that they're going to do is going to align with our overall strategy, our vision, our mission, help to reinforce our values. And our employee resource groups do that. And the Gender and Sexuality Alliance group is phenomenal in its work and what it does as well. So making sure that financial support and that senior leadership support is there for them is something that I would, if you have the ability to do that, it is, I think, really tremendous, and it really sends a very loud and strong message to our employees that we see you and we recognize the work that you do, and we know that this organization could not be as strong as it is if it was not for you. To just expound on something that Bobby said in in becoming a leader within the Health Equality Index. And if you have not participated or you're not familiar, let me say more so maybe if you're not familiar, because we just participated this past year with the Healthcare Equality Index. For Bobby's institution to have achieved a leader status and 100 points is really phenomenal. And I know he kind of just glossed over that, but it's really and truly tremendous, given the rigor, I think, and the requirements that are necessary. It says so much about what his organization has really done to update policies, update practices, and ensure that they're implemented throughout the organization. And so if you can take a look at the Healthcare Equality Index, that's another thing that I think is a very good starting point. No matter where you land, what I think is so helpful about it is it at least provides you with a guide. It is an assessment where you can begin to examine your institution, and it's really for more of in the inpatient setting. They're looking at expanding into the outpatient setting, but it most certainly, if you are based in a hospital, tertiary care, 24/7 delivery system, it is very, very helpful at least to say, where do we want to begin? Like, where do we maybe have some gaps? And so it allows for your institution to do that internal assessment. And Dartmouth Health Medical Center, as well as another one of our member sites, Alice Peck Day, went through this. We went through review process last year. It's available, or at least the reporting is available once every other year, and it's nice and able to be on the list because it does send a message to your community that this is of importance to us. We prioritize this for members of the LGBTQ plus population. We heard from our employees that they will at times make a decision about whether they go to one hospital or another because they see that a hospital has a particular ranking or has a particular status, think about it like leapfrog. Do you necessarily want to go to the hospital that has a leapfrog C status? No, probably not. You'd rather go to the hospital that has a, leapfrog A status, because you know that they've met the requirements in terms of patient safety, and that they really are prioritizing patient safety. So when we went through that assessment, we came in at the builder status. That was the beginning level. But it at least provided us with a roadmap for us to say, this is a starting point. What now more do we need to do? Where might we get the greatest return on our investment? Is this the area, the next part that we really want to focus on? And so to continue that work, we created an LGBTQ plus task force. And this is a system-wide task force led by two of our senior leaders within the organization, bringing together representation from all of our member sites. It allows for collection of resources, sharing of data, sharing of best practices, really bringing in also community health partners to help us engage in this work. And this task force is just starting to take off, but now that it's kind of finding its rhythm, it's finding its groove. I think our members are finding that this is very beneficial to hear what's happening over at site A is maybe something similar is happening at site B, or site B was hoping to get that up and going. So now how can they lean on one of our sister member sites in order to bring that over without duplicating resources, but instead really expanding on the work that has been done. So the Healthcare Quality Index is one of many assessments that are out there, but I think it was dropped in the chat box for you, and thank you for that, Bobby. I really would encourage you at least to look at it, review it, because it can be a starting point if you're not sure where to start, because there's so much information that's out there and that's available. The last thing that I think I wanted to mention was around the SOGI data, and that we did embark upon this at Dartmouth Health within this last year. One, because we knew that it was coming in terms of CMS requirements, and if I think I'm going to say our organization is one that it's important for us to receive reimbursement for the work that we do, and two, we also really knew that it was the right thing to do. We again, listening to our patients, listening to our employees, they wanted this information to be part of their electronic healthcare records. Now, we also knew that there was going to be a population of patients that were going to wonder, why are you now asking me this information? I've been a patient here for many years and nobody's ever asked me this information before. Why is it now relevant? And so for us to roll this out, we looked to our OBGYN colleagues who had already been doing this work within the hospital, who had tremendous response rates. So they were pretty much at over 90% of their patients completing the SOGI data when asked, and pretty much 100% patient satisfaction. So they really were not receiving pushback from their patients or objections from what the patients from the patients being asked this information. So we put together a work group that would look at this from an IT standpoint, what needs to be necessary, and then what the questioning was going to entail, and then where we were going to roll this out. And so we chose to do this within the outpatient setting for our primary care specialty specifically, and then also ensure that our subspecialties would be informed and would know, so that if a patient had gone to primary care, had entered all of this information, that then when they go from primary care, and then maybe go to orthopedics, or maybe go to rheumatology, or maybe go to gastroenterology, it's it's not as though the thumb hasn't been talking to the pinky finger. We wanted to ensure that our subspecialists were aware and knew that this information was available and in the EHR and where they could access it to again tell our patients, we hear you, we support you, and we want to respect you. So that's just, hopefully that's been helpful in kind of sharing some of the work that we've been able to do on a system level. We of course have a lot of work still to be done. We've made mistakes along the way, but I think the beauty of making mistakes is that we learn from them. We take the time to pause, reflect, dissect, reevaluate, and pivot as we need to, with keeping in mind every step of the way our mission is to deliver world-class care. And in order to do that, our patients have to be valued and respected and heard and feel included. So thank you.
So I just am so grateful and thank you so much to our three panelists this afternoon, Bentley, Bobby, and Terry, for not only your vulnerability, but sharing your background, experiences, and insights with us. You each provide a different lens of this work, and I really appreciate it. I know we could probably spend a full day going through a lot of different things, but unfortunately, we only have another half an hour together. We're now going to transition into breakout rooms for the next 15 minutes. This will be an opportunity for us to discuss anything that came to mind and any questions you may have after listening to our panelists this afternoon, and then think about things you may want to bring back to the Q&A and our final 15 minutes together. So we will break off now and we'll come back together around 5:15 to then conclude the session. So okay, I think we're all back. So we will now open it up to some Q&A for the next 13 minutes or so. And so is there, oh, Bobby and Mark, would you like to start with your panel?
I think we appointed Kathy Bizzaro to report out. She had a great question that led to a lot of discussion. So maybe Kathy, share.
Sure. Thanks, everyone. Kathy Bizzaro Thunberg, Executive Vice President, New Hampshire Hospital Association. And our group, we talked about a couple of different things. One was the role of compliance officers in hospitals and how they can be a good facilitator for supporting changes to forms, changes to training, changes to, other policies in order to move a hospital forward in being able to be more responsive to LGBTQ community. The other topic we talked about was the fact that despite the fact that we want to be as proactive as possible, the reality is there is some reactiveness that we are prompting action within hospitals. So I think, we understand, I think Dr. Kelly said prevention and, that's his role as a primary care physician, as, focusing on prevention, but there's always some reaction that we have to do. And I think that's just a reality. But the more proactive we can be, the better, obviously. So I think it was a good conversation about, opportunities to see where we can move the needle. Mark, I hope I covered what we discussed.
Thank you. All right, Bentley, would you like to share from your group?
Yeah, absolutely. We didn't appoint a speaker. I should have thought of that while we were in our breakout, but we had some really robust experiences about lived experiences in our own organizations. Sherry had mentioned the importance of really incorporating a patient's voice in care designs and education with staff. And this was in particular a transgender patient that they invited to be part of the conversation. And then Ashley had brought up showing how we show respect for our patients via sort of intentional workarounds that were designed to meet a transgender patient's name, affirmed name, whereas in legal documents, it shows up as a different name, and really being mindful of that. And then the last story that we heard was from Joe, and it was all about how we really encounter bias. It can happen everywhere, and how we stand up to it. And we can do that through upstander training, which is definitely an important part of workforce development. Really being able to equip people with how to say, hey, I noticed something that made me feel uncomfortable, or that I think might have hurt this other person's feelings, and utilizing that to improve somebody else's experiences. It's sort of like the active service recovery, and being able to apologize and then use that for a process improvement.
Thank you. Terry.
We didn't appoint a speaker either, so I'll just give a couple of bullet points from our group. One, there was definite gratitude and appreciation, and shout out to Bentley for his presentation, for the slides, and particularly going through what the acronym LGBTQ plus stands for, and that knowing that terminology can evolve, and what it means to one person, it may not mean the same to another patient. So don't make assumptions. But it was very helpful to have that overview. Also, just some sharing of wins, and just really celebrating that we're all on this journey, and to have a win of pronouns maybe now being incorporated into email addresses, or part of employee badges, or maybe having the rainbow flag incorporated into any flyers or communication. That may seem like a small thing, but it can have a significant impact, and a very, very positive impact for patients to see themselves represented, and to know that a healthcare organization has even taken the time to add this in. It really speaks volumes, and you may not always hear it, but if it's allowing a patient to leave with a positive experience, you've made a difference. And then also just kind of sharing of some of the challenges that we have with moving this work forward, that we may have employees, close colleagues that question us, and maybe even oppose what it is that we're trying to do. They may not be obstinate and refuse, but they're just questioning why are you doing this, and so kind of how we can also support each other through those challenges, but how important it is to continue to forge ahead, and to not stop just because someone were to question. But it's very, very important, I think, to have your why, and to have that why available in your back pocket, because it's going to come up that someone's going to ask you why are we doing this? Why is it important? And so you may have to change it and modify it for your audience, but have that why, because it will be asked of you.
Thank you, Terry. I'll share some just some perspectives, and I have one question that was asked for us to bring back to the panel. There was definitely an appreciation for your vulnerability and sharing your stories. That was a resounding, across the board. There was, Mary had mentioned about legislation in some of our states, some of the states within the country, such as Florida, and how that can really pose challenges for this population, and the perceptions of healthcare, as well as providing a safe medical home and psychological safety for our patients that may be coming to see us. Steve talked about how we continue to meet people where they are, and a better appreciation across the board for their background and history. So the question that I have for the panel is the question is there a more sensitive way to ask a patient to share their gender on a form besides asking your gender assigned at birth?
I think when we're talking, sorry, this is Bentley. I was just wanting to chime in that I think when we're forming these relationships with our patients, I think that a big part of this is to foster that sort of connection, and that helps build psychological safety, and sort of being able to ask a patient, we can reframe that in ways of, I want to be respectful and address you with the pronouns that you would prefer. I see listed here is this. What would you prefer to go by, so that I can be respectful of your needs, is a great way to show that we are making the effort to meet that patient where they're at, and be respectful of how they would like to be called.
Yeah,
Go ahead, Bobby.
You can hear me? I'm sorry, I'm in the car. But I felt like this was an important thing to just address. I agree with what Bentley said. But also, I often will say, if you need information at different stages of the patient journey, right, that for registration, for example, we sort of need the legal sex, or the sex that's the marker that is on the patient's insurance card. Like, that's often the part that's important there. And in the exam room, when I'm a clinician talking to a patient, wanting to understand the medicine that's going on, there's Fenway Health has a best practice based on an organ inventory. Things that are important to know, if just as if you were a cisgender woman who had a hysterectomy, who doesn't have a uterus anymore, it's important to know. On the flip side, if you are a trans man, if you have a uterus, it's important to know that as well. And so that's obviously not something that would be asked at registration, or it could be, but you would need very sensitive registration staff to be able to have that conversation, I think, appropriately. So I don't know if that answered the question, but there are different ways to gather the information that needs to be gathered at different points of the patient journey.
Right, thank you. We had a brief conversation, or just talking about the challenges of being in a rural area, and how we have a lot of people who know people, and it's a very tight-knit community at times, and how to be, sensitive and aware of that as well. So, any last thoughts, any questions that come to mind at this point? Okay, well, thank you all for joining us this afternoon, and hanging with us. Tia did put information in the chat on how to fill out the evaluation, which is really important at the end. And we will be sharing information in terms of additional resources and any other references that may be helpful to you on your own individual journeys. So thank you again for your time and attention this afternoon. And I hope you have a great rest of your evenings. Thank you.
Thank you.
On behalf
Thanks.
of ACHE, I want to thank our chapter leaders that planned today's session, our moderator and panelists, and all of you for your participation. Please complete the evaluation, which is open for 1 week. The direct link is in the chat box. You can also access the evaluation by visiting your My ACHE page and selecting My Online Learning from the Helpful Link section on the right side of the screen. From there, click on the Access My Courses link and you will be directed to our learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within approximately 2 business days. Everyone who attended today's event in its entirety will see their 1.5 hours of virtual interactive education credit posted to their My ACHE account within 2 weeks of this event in the My Education Credit section. That concludes our session, which is copyrighted in 2025 by the American College of Healthcare Executives. All rights reserved. Thank you, everyone, and enjoy the remainder of your week.